Well, we're in store for a very exciting day, and I'm really happy we get to start off with three excellent speakers that are going to bring us up to speed on clinical manifestations of SARS-CoV-2 virus. We have Dr. Krishan, Dr. Srinivasalu from our center, and Dr. Newberger from Boston Children's. And I'm going to start by just reminding everyone each speaker will speak for 20 minutes, but then we will reserve questions for 20 minutes at the end for a group Q&A. So without further ado, I'm going to introduce our first speaker in this session, and this is Dr. Anita Krishan. Anita is a pediatric cardiologist here at Children's. She's been here since 2009 as a faculty member after completing her residency and fellowship, as well as advanced cardiac imaging fellowship here. She's been really an integral member of our MISC task force here at Children's since its inception, and she has a lot of research interests, including neurodevelopmental outcomes of neonates with congenital heart disease, the impact of social disparities on diagnosis of congenital heart disease, and long-term outcomes of these children. She also has expertise in diagnosing fetal arrhythmias in conjunction with diabetes and other connective tissue disorders. And she also has performed prior research at NHLBI looking at high-resolution imaging techniques to characterize early human and mouse cardiac development. So because of her expertise with Miss C over the last year and a half, we're going to have her give the first talk, which is entitled Cardiac Manifestations of COVID-19 in Children. Thank you, Anita.
Thank you so much for the invitation today, Dr. DeBiasi, and I'm really looking forward to my co-panelists' talks as well. So my objectives today are to describe the mechanisms of cardiac injury from COVID-19 in pediatric patients and the pediatric patients who may be at higher risk, to describe the spectrum of cardiac disease in MISC and or acute COVID infection, and then to discuss the long-term cardiac outpatient concerns, including return to play and long COVID. So to begin, some background. As most of you are aware, in the early months of the pandemic, the proportion of pediatric cases was low, but now as vaccination rates have increased, younger patients are a more significant proportion of the new cases, although fortunately the numbers are low overall. Pediatric mortality, which would also reflect the cardiac disease burden, has also been quite low relative to the total population, as you can see here. The total MISC cases as of the beginning of the month were about 3,742. And to give you a relative comparison, there have been a total of 4 million pediatric COVID infections reported, less than 2% of which resulted in hospitalization. The impact of the virus on the heart is related to the structure of the heart. And as are all familiar with, SARS-CoV-2 is a single-stranded RNA virus. Its spike protein binds to the ACE2 receptor and enters cells by endocytosis. And ACE2 is expressed in a variety of tissues, including cardiovascular tissue. There have been several mechanisms proposed for cardiac injury, including direct injury by the virus, inflammatory response, cytokine storm, hypoxic injury, iatrogenic injury from the drugs, inotropes, and ventilation that we use, and then underlying illness of the children affected, which may cause low cardiac or cardiopulmonary reserve. There's some data from histologic findings to give us clues as to the mechanism of injury. So this study presented autopsy findings from a child who passed away from MISC and showed findings similar to myocarditis, that viral particles were isolated in the myocardium, inflammation was found in the myocardial tissue, and areas of necrosis were seen as well. There has been a lot of anxiety among patients in our group about who is at the highest risk. The highest risk congenital heart disease patients are single ventricle patients, patients with cyanotic heart disease, cardiomyopathy patients, patients with pulmonary hypertension, heart transplant, unrepaired CHD, coexisting disease like Down syndrome or 22q11, or adult congenital patients who have coronary disease or hypertension. The spectrum of cardiac findings in COVID-19 are comparable to other forms of myopericarditis, with the addition of the coronary aneurysms or ectasia that we see specifically in MISC. It also can include endocarditis with significant mitral, aortic, or tricuspid insufficiency. We see ventricular dysfunction that can be subclinical. Pericardial effusions are common, usually small, but there have been cases of really large ones causing tamponade described. Coronary artery aneurysms and ectasia, similar to in Kawasaki syndrome. And then, as with any form of myocarditis, intracardiac thrombi can be seen. Similar to with myocarditis, there can be injury to the electrical system. And so sudden cardiac death and VFib have been described, sinus node dysfunction, AV block ranging from first degree to high grade. Prolonged QT or Brugada syndrome can be unmasked. And then there are several single center series looking at the types of arrhythmias that can present both SVT and first degree AV blocks. Another common question is which patients need diagnostic imaging? So currently our protocol, similar to other centers, is to image all inpatients, although patients with no signs of myocarditis can be deferred until they are not infectious. Outpatients who have cardiac symptoms such as palpitations, syncope, or fatigue with exertion. All patients with MISC undergo serial echocardiography, and it can be considered in sports clearance for competitive athletics. And then as part of the CNH-NIAID study, the lab in conjunction with Dr. DeBiasi and Dr. Harache have developed a large-scale comprehensive research and imaging protocol. What do we look at on echo? The protocols we use are similar to those in myocarditis and Kawasaki syndrome. We look at right and left ventricular systolic and diastolic function, valvular regurgitation, the pressure in the right side of the heart, the presence of pericardial effusions, and then measure coronary artery size, including Z-scores, which are standardized measurements of the coronary relative to the body size. This shows an example of speckle tracking echo, which is a tool that has a lot of power to give really detailed information about heart function. So the map here on the left is normal, and then this one on the right is abnormal. So strain traces the inner and outer layers of the heart tissue to understand how each segment of the heart is twisting and untwisting, and can identify really localized areas of disease. So here you see the blue indicates abnormal strain or potentially diseased myocardium. Ashraf Harache reviewed our experience with MISC and evaluated the imaging findings in a cohort of patients. So in 39 patients, abnormalities were found in a total of 19. These included 8 with coronary artery anomalies and about 1/3 who had findings of systolic dysfunction. And here I show some images. So this is a patient with moderate left ventricular dysfunction, and you can see that the posterior wall is not moving well. This is one of our sickest patients in the cardiac intensive care unit. So this blue jet here is moderate mitral regurgitation. And this patient had significant atrial arrhythmias, which ultimately normalized, and her function now is normal. And then this is a pretty common finding of coronary ectasia. This actually classifies as a small aneurysm. The left coronary Z-score was 2.8, which puts it in the category of a small aneurysm. There are a few single center studies looking at strain abnormalities, and more detailed information will be coming out in the multi-center trials that are underway. But Kevin Friedman and his group in Boston showed that there were subtle abnormalities in strain in those who had an abnormal or who had a normal ejection fraction, and that these persisted in about a third of patients at the time of discharge. The group at CHOP compared about 28 patients with MIS-C versus healthy controls, as well as a cohort of Kawasaki patients. They found that only 1 in 28 patients had a coronary abnormality. This is lower than in other studies and other single center experiences. And they also found altered strain in patients who had preserved ejection fraction. And what was unique about their study is they found differences in the way that atria moved, which is something that's seen in adult patients, but is not well described in children. MRI is a gold standard tool for evaluating myocarditis in the pediatric population. Its role in MIS-C is clear, but is still being defined as to exactly which patients would benefit most. Currently, we're harmonized to the music protocol that you'll hear about later, obtaining MRIs in patients with an ejection fraction less than 45% or who have suspected myocarditis, either from very high troponin and BNP in association with shock. It's not typically done in the acute phase, so we get MRIs between 3 weeks to 6 months after COVID. And there are limited publications on MRI findings in MIS-C, mostly in the setting of just small case series. But we could see increased T2-weighted signal or extracellular fluid. And sometimes we see areas of delayed gadolinium enhancement, which is where contrast sticks to areas of diseased myocardium. And then finally, what are the long-term outpatient concerns? I think in day-to-day practice, many cardiologists are being asked, when is it safe for children to return to play? And obviously this is different for pediatrics than adults and actually varies quite a bit based on age. So children who are older than 12 or playing collegiate sports are quite different than kids who are playing recreational soccer in elementary school. Prior to COVID, we knew that myocarditis is a risk factor for sudden death in younger athletes and frequently lacked preceding cardiac symptoms. So in a letter to the ACC, Peter Dean asked us to reflect on how recent is the infection, how severe is the infection, and what is the sport. Typically, return to play is recommended when children have been symptom-free for at least 10 days. They have no clinical or laboratory evidence of myocardial involvement. Asymptomatic or mild patients who are not receiving testing during the acute illness don't need further testing. But any child who's been hospitalized or who has had MIS-C, and particularly if they've been hospitalized in the ICU, are restricted for 3 to 6 months until cardiac testing has normalized. There are multiple algorithms for return to play. This is the one that we've been using at Children's National. So pediatric patients with a history of COVID-19 who were asymptomatic for 10 days, if they were admitted to the hospital due to COVID, if they were found to have abnormal testing, or if they had MIS-C, they are referred for cardiology clearance. If not, they the provider can administer the AHA 14-point checklist, and if there are any red flags, refer to cardiology. And then the ACC and the AAP both have sets of guidelines which providers can use to help decide whether cardiology referral and diagnostic testing is indicated. And this is the AHA 14-point screening that looks at personal history, family history, and physical exam findings. I think some of this is still in evolution as we decide what testing is needed. And this is a large study that came out last week, but has been talked about for quite a while, looking at Big Ten athletes and doing both clinical screening and CMR imaging. It evaluated over 2,000 athletes for symptoms of myocarditis. They screened symptomatic patients with CMR as well as asymptomatic patients. They found that 2.3% of Big Ten collegiate athletes had MRI evidence of possible myocarditis, with 2/3 being subclinical and found only on MRI. Only 5 would have had clinical symptoms to warrant testing. So MRI increased detection by a 7.4-fold factor, but there is still a question of what to do with that information since we've never screened athletes post-viral infection in such a large scale before. And then finally, the next frontier will be long COVID. And we are beginning to see patients with this present to our clinics. This is a constellation of symptoms, including fatigue, orthostatic intolerance, chest pain, and palpitations. It can limit school attendance, and then kids may be very limited, although their cardiovascular testing is normal. So you can consider autonomic testing and treat with typical therapies for POTS, depending on the degree of severity. So in conclusion, cardiac disease fortunately is rare in the pediatric population exposed to COVID, but does require careful surveillance. Advances in imaging are helping us to define subtle cardiovascular changes that need further study. And understanding long COVID and the return to play guidelines is important to get kids back to normal and doing the things that they love.